Just gastrointestinal pathology today, summer 2020, week 5. And this is all 3 of Thursday's lectures combined. Off we go. So the first thing we need to remember is the hipster. What did hipster stand for? Well, it stands for the juices that come out of the oxyntic gland. So we have hydrochloric acid, intrinsic factor. Those come out of what gland? No, not chief cells. Parietal gland. What's P? That's pepsinogen. Where does that come out of? Those comes out of chief cells. Let's see. So its job, of course, intrinsic factor. We're going to talk about it here in a second. But it binds to vitamin B12, holds hands with it, so it doesn't have to travel alone down the small intestine. And then it takes it all the way into the distal enterocytes. But we're going to dig into that here in a second. In fact, that second is here. Let's talk about vitamin B12 or cobalamin. It is a water-soluble. Who are the fat-soluble vitamins? Easy for me. I had one of my first associate doctors was named Deek, D-E-A-K. So those are them. Vitamin D, E, A, and K are the fat-soluble. So this is a water-soluble vitamin, but it's a little bit weird because this one is storable. Remember, water-soluble vitamins usually are not stored in the body, but this is a rare exception to the rule. It's very important in myelin sheath kind of maintenance, and it's very important in erythropoiesis, especially. It's important in hematopoiesis, the formation of blood elements in the bone marrow, but it's particularly important in erythropoiesis, which is the building of red blood cells. So super important dude. It's also, it can't be made in our body. We are almost completely dependent on it. We could not live if we didn't get an external source. It's made by some bacteria and algae. And yeah, so we're 100% dependent. A tiny bit is made in the gut by gut bacteria, but that's not enough for life. You need 2 to 3 micrograms of it a day. The good thing about it, if you do go on a run of eating eggs and eat a lot of vitamin B12 containing foods, liver and shellfish, you can store it in your liver and you can build up stores that can last a couple years, which is quite amazing. It can be stored in the liver, and that's very unusual for a water-soluble vitamin, for a couple years' worth. And as I said, the rare exception of a water-soluble vitamin being stored. And if you run out, if you get stranded on a desert island and you're out of B12, you can live for a couple years with that supply in your liver, but you're going to have trouble after that time period. Pure vegetarians, they have to get it from something, and they usually get it from yeast, and there are some other sources. How does it get into the bloodstream? Now, we got to understand this to understand pernicious anemia and vitamin B12 deficiency, and we got to understand this. So this is a story I love to test on, and boards love to test on, and everybody loves to test on this story. So you eat a piece of meat, or let's say you have an egg. I usually use a piece of beef liver or something, but you can have an egg that has vitamin B12 in it. And so inside protein, vitamin B12 isn't floating around naked. It's bound to certain carriers, and we're just going to call them food-binding proteins because they're all similar. Okay, so you get it in, you chew it up. That act of chewing, of course, is called mastication or masticating. So you masticate up your food. The salivary enzymes are flowing because of the vagal stimulation. So then you're getting ready to swallow. The act of swallowing is called deglutition. I'm sure you already know that. I will assume you know that word for the test. And you can chew and chew as much as you want, but vitamin B12 will still be bound to its food-binding protein. before we swallow, one more thing, and this is a big player here, heptocorrin. So sometimes it's called the R protein or the R factor or transcobalamin 1 or holoheptocorrin. So technically, a side note here, there is something called an aptoheptocorrin that is in breast milk. So you really shouldn't, you really should call it holoheptocorrin, because you shouldn't just call it heptocorrin because maybe you're talking about aptocorrin. So, but nevertheless, Robbins calls it heptocorrin, and that's how it'll probably be on the boards. But it might be for medical students and such. Might be R protein is a more popular word. It comes from all the salivary glands. Remember them? The parotid gland, the submandibular gland, sublingual gland. It's a glycoprotein, and it doesn't do anything yet. It just kind of gets mashed up in the food, and it's looking at vitamin B12, but nothing happens yet. It is physically impossible for it to bind to vitamin B12 yet. Notice I say yet. So there we are. We're chewing up. There's our food-binding protein. There's our B12, and there's our heptocorrin, and they all go down in a big bolus of food here, heading toward the stomach. In the stomach, what happens? Well, what's in the stomach? Acid, pepsin. So in the stomach, vitamin B12 is broken loose by the actions mainly of pepsin. So super important. Where's pepsin come from? We already know. The chief cells. Where do the chief cells live? In oxyntic glands, aka for oxyntic glands, fundic glands. So HCl is important because that, amongst other things, breaking down proteins, it converts pepsinogen, chief cells secrete pepsinogen, right, into pepsin. And pepsin can actually break down pepsinogen into more pepsin. So pepsin, once it's formed, can help hydrochloric acid. Once that happens and vitamin B12 is no longer bound to the food-binding protein, right, because pepsin just knocked it off there, it's naked and afraid. But not to fear, because vitamin B12 sees heptocorrin and jumps on its back. Well, of course, it doesn't jump on its back, but it binds to it very strongly, and it's happy and safe, protected from stomach acid. B12 would be destroyed very quickly in the acid environment if it weren't bound to heptocorrin. Intrinsic factor, kind of like the heptocorrin story, intrinsic factor is also released from parietal cells, and it's looking at vitamin B12, but they don't do anything yet, but it's right there by it. So everything gets squirted out of the stomach into the duodenum through the pyloric sphincter. Okay, let's see. So once we're in the duodenum, we have the pancreatic proteases floating around, specifically trypsin and chymotrypsin. Right? Those are the main pancreatic proteases secreted from the pancreas. And those guys, they attack the heptocorrin and rip it off. And once again, vitamin B12 is naked and afraid, but not to fear, because there's a new partner for vitamin B12, and it's its main partner. It binds immediately to intrinsic factor. Intrinsic factor and B12 then hold hands and go all the way down to the distal ileum. Here's a little cartoon. Boards are coming. You need to remember this stuff. Enterokinase, got some AKAs to it, but enterokinase is how I learned it. It sits on the duodenal microvilli of the epithelial cells there. And the pancreas secretes trypsinogen. Trypsinogen is converted by enterokinase into trypsin. Trypsin then can, besides break down proteins, it can also kind of auto-convert itself. It can hit other trypsinogen and convert it to trypsin. And unlike pepsin, it can also take chymotrypsinogen, which was secreted from the pancreas, and convert that into its active form, chymotrypsin. All right, so there's the story where we're at so far. So now we have proteases, pancreatic proteases, trypsin, chymotrypsin, broke heptocorin loose, vitamin B12's naked and afraid, never fear intrinsic factor is here. Hey, that rhymes, doesn't it? Never fear intrinsic factor is here. They bind together, and now together, hand in hand, they head down for their destination, the distal ileum. They go through the jejunum, they go through the ileum, but when they get to that last part of the ileum, that's where Batman lives. So Batman, it's not really Batman, of course, but there are receptors called cobalamin receptors. One of my favorite shows, one of the only shows around back before the invention of the internet, back in the late 60s, I remember couldn't wait to watch The Real Batman. And you go look, and they when they're fighting, when he's hitting a bad guy, they have these little signs come on. It says kabam, and that's the way I remember cobalamin receptors. The Robbins calls them cobalamin receptors, but the strong AKA Rubin's cobalamin receptors. So it could be either one of these that show up in chiropractic boards. And there's a bunch of other AML receptors, cobalamin, amylase receptors. Those are just kind of bizarre ones. But cobalamin receptors, they live on the distal enterocytes, and their job is to snag the vitamin B12 and intrinsic factor complex that is floating by. And once they snag it, they reel it inside the cell by endocytosis, and very quickly the complex is swallowed by a lysosome. And that's like the giant Death Star, right? If you're a Star Wars fan, it's swallowed. And then inside the lysosome, the B12 is released again from the lysosome, or it's broken off from the intrinsic factor. The intrinsic factor is destroyed. But amazingly, the vitamin B12 is not harmed by the lysosome and is spit out. And then the vitamin B12 is carried out of the bottom of the cell, the basolateral surface of the cell of the enterocyte, and now it's spit into the intersystem right by the capillaries, the microcirculation, but it's now naked and afraid again, so it doesn't like to travel by itself. Never fear, we have transcobalamin 2 is here. Boy, I'm just in a poet mood today, aren't I? I don't know why. It's Monday. Mondays are usually kind of a blah day, I guess. I don't know what's the matter with me today. Maybe because I went on a walk and I had some endorphins released. But anyway, so vitamin B binds to another partner, transcobalamin 1. Remember, heptocorin, aka, was transcobalamin 1. Sorry, this one, vitamin B12 now binds to transcobalamin 2. Transcobalamin 2 is made by those same distal ileal cells that have the cobalamin receptors. So together, they jump through into the capillaries, and they get into the interstitial veins or the intestinal veins, and then they go into the superior mesenteric vein. Remember your highways, and then they go through the hepatic portal vein, and they get into the liver, and they're stored in the liver. They get into the bone marrow. Some gets back into the intestines. It can be delivered everywhere. Remember your anatomy. There's the hepatic portal vein. Remember, it splits into a splenic vein. We saw these in Gross 2 lab. And there's a superior mesenteric vein here. Inferior mesenteric vein could come off either one of these. They have it coming off the splenic vein. It could come off the superior mesenteric vein. It could come off kind of the crotch here of these two. The point is, here are the intestinal veins, and we saw those. I used to pin those in class to test you on those things. And that's the pathway. So that's where our transcobalamin 2 and B12 is headed for the liver, where most of it is stored. Then it goes to the bone marrow. All right, there's a cartoon of that same thing. Yep, carried to the bone marrow. The liver, it's the first place it's carried to. Then it's distributed. Some of it is stored, but leftovers is released and gets into the bone marrow and into the nerves. And it's used for hematopoiesis and myelin sheath repair. That's a little more mysterious, that system. We know more about what happens in the bone marrow. Is there another way to get B12 into the bloodstream? Not really, but there is there is another way to get it. It doesn't work very good, but we've learned that 1% of vitamin B12 that's taken in can actually be absorbed through the enterocytes of all the intestines. And it's not enough to sustain life, but if you superdose or megadose vitamin B12, you can kind of put off vitamin B12 injections for a little while, because that's where people with pernicious anemia are headed. They're going to need vitamin B12 injections. So superdosing does have an effect, and it's supposed to be no harmful sequelae to anything else. So, that's a way to avoid. Eventually, someone with pernicious anemia is going to have the intramuscular injections, but it does help at the beginning. To that end, we need to talk about this now. Be warned here, this is quite a bit different than last quarter's lecture. I just had to manipulate these slides a little bit because the medical texts I use that are much better storytellers than Robbins just were enough different where I'm getting a little concerned. So I'm telling the story more through Rubens and Robbins' eyes, but still telling it in a medical school way as well. So it kind of benefits everybody. And it's a complicated story. I worked on this over the weekend. It's kind of got me behind a little bit to put this together. But here's the story. So pernicious anemia. And here's where they differ from like Winthrope's hematology, which is a very famous hematology. Medical students use this. We don't even have a hematology class here, which we should have, but we don't. They call it type A pernicious anemia. And the A stands for autoimmune disease. So for medical students, that's a strong AKA. It is, when you hear the word pernicious anemia, you should think autoimmune, especially chiropractic students. That means it's an anemia, of course, low red blood cells, but it occurs secondarily to an autoimmune attack, mainly against parietal cells. And there's some other autoimmune targets. So you screw up your parietal cell, there goes your intrinsic factor, there goes your holding hands with vitamin B12. You get a vitamin B12 deficiency. And there are some other targets we can look at. Now, what predates the autoimmune attack? Now, this is Robbins, so this is not confirmed by some of the medical books. But Robbins says, unreferenced, so I don't know where this came from, but Robbins says that there's evidence that before the autoimmune attack occurs, a neutrophil-heavy inflammation can be found within the fundic region of the stomach. So it's kind of like one of the gastropathies we're going to study. And that inflammation kind of rewrites the genetic code in some of the parietal cells and chief cells and other members of the fundic glands to the point where the body no longer recognizes them and it sparks an autoimmune attack. So inflammation is at the root of this attack. That's why not everybody has autoantibodies to the parietal cells or to the fundic glands. So that would explain the theory of why that is. Then it's just an inflammation, which would mean then it's really not a pernicious anemia. It would really be one of the gastropathies that we haven't talked about yet. But for simple purposes, without going into the weeds, and for studying for boards, pernicious anemia is an autoimmune attack against the parietal cells. And that's the usual cause of this thing. Okay, we'll look at pernicious anemia B and some other types of pernicious anemia. They really shouldn't call it that, and that's what makes it confusing. Or if they're going to call it that, then this one should be officially pernicious anemia A. If we're going to have a pernicious anemia B and C. But Robbins does like half. He doesn't mention the word pernicious anemia A, but then he talks about pernicious anemia B, which is like very confusing. But anyway, I digress. So, of course, the parietal cells, we know that they make intrinsic factor, so we knock that out of action. You can't absorb vitamin B12, so you get a vitamin B12 deficiency. And In and of itself, vitamin B12 deficiency doesn't do anything. It is, however, well, I mean, it does stuff. It does bad stuff. But that's not the disease. Vitamin B12 deficiency is one of the two members of a class of anemias called megaloblastic anemia. You can also have a folic acid deficiency, a vitamin B9 deficiency, can also cause megaloblastic anemia. And they present almost but not exactly the same way. So maybe perhaps it'd be better to get rid of the word megaloblastic anemia and just describe vitamin B12 deficiency or vitamin B12 anemia and folic acid anemia. But they don't. They clump them together into this. You don't see a vitamin B12 deficiency anemia. You only see megaloblastic anemia. So that's another thing that's kind of confusing about this story. But I said there were some other autoantibodies. We'll talk about those here in a second. But there are autoantibodies that some people have against intrinsic factor itself and the cobalamin receptors or the cobalamin receptors. And there's even another text, Orkin, talks about G cells. There are some people with pernicious anemia have autoantibodies about G cells. More likely than not, over 50% of the people have antibodies to all of this stuff. Cobalamin receptors, intrinsic factor, and most importantly, the proton pumps of parietal cells, which live in fundic glands, aka oxyntic glands. See how you have to know all that terminology? If you forget that terminology from last quarter, you didn't even know what I said. I might as well be talking Greek to you. That's why you got to know that terminology so you can understand the language. Let's look at these antibodies. Type 1, I do like these antibodies, so good stuff to remember. Type 1 autoantibodies goes after intrinsic factor itself. That's the one we just talked about. And it destroys specifically the binding site, intrinsic factor's binding site for vitamin B12. Therefore, B12 can't bind with intrinsic factor, and therefore B12 will not be taken up in the distal ileum. So it can't get in the bloodstream, so you got yourself a vitamin B12 deficiency or megaloblastic anemia. This is present in about 75% of the patients with pernicious anemia. Type 2, these ones go after the cobalamin receptors or the cobalamin receptors of the distal ileum. So they mess up the receptors again from inflammation, and there's nothing wrong with intrinsic factor unless you have that autoantibody as well. But if you don't, if you just have a type 2 antibody, B12 and intrinsic factor come happily down the pipes, and they say, oh, distal ileum, look, there's our cobalamin receptors, and they try to bind, and cobalamin receptor just gives them the hand, says, I don't feel good, get out of here, and you can't bind, so you can get a deficiency of vitamin B12 that way. About 75% of the patients have that type. And type 3 autoantibodies, that is by far the most common. 90% of people will have these, maybe other ones as well. These attack the parietal cells, specifically the hydrogen-potassium pumps are attacked and inflamed and destroyed. And we talk about collateral damage. Once you get an inflammation of the parietal cell, it spills over into the adjacent cells, including chief cells, D cells. Just the whole fundic gland gets inflamed and destroyed and eventually absent. What's the clinical sequelae of this inflammation attack against the stomach? Well, you get a B12 deficiency, which leads to megaloblastic anemia. You also get an upset tummy, and that's called dyspepsia. And specifically, it's called organic dyspepsia because we know the cause. There's a functional and an organic. Functionals, we don't know the cause. It's by far the most common. Organic, like secondary hypertension, means we know the cause of it. And the cause of it is type A pernicious anemia, or an autoimmune attack against parietal cells. Will these patients have trouble with GERD? That's a nice question, right? That's a nice softball question. You should be able to crush that. Will they? Gastroesophageal reflux disease? Will they? Will they? Somebody answer me. You can't answer me, right? Because I'm doing this ahead of time. No. Why not? Well, what else does the parietal cell make? Hydrogen, hydrochloric acid. So these people will be hypochlorhydric. They won't have a lot of hydrogen ion and chloride ion around. So you have to have acid to have GERD, so these people will not have GERD. And they will have a stomach condition, one of the gastropathies, called chronic atrophic gastritis, aka autoimmune gastritis. Those are Robbins terms. There's like wait till you see the AKAs for the gastropathies. It's just incredible. One of them has 2 slides of AKAs. It's just absolutely, GI docs need to get their ass together. It's the biggest mess. You're not going to believe the mess when we get there. But anyway, Robbins calls it chronic atrophic gastritis because it does destroy the stomach. Histologically, it doesn't. Well, you can even see it. If it's really bad, you can even see it with a naked eye. Okay, clinical sequelae. Anything else? Well, what about stomach juice findings? Stomach juice findings. Did I miss one? I did miss one. No, we'll get to that when we get to blood work findings. What about stomach juice findings? Take a sample, stick a tube down their nose, down their stomach, and take a sample of some juice. Expose them to a picture and smell of steak and get the stomach juices flowing, and then go take a sample. Well, they're not going to have enough hydrogen ions, so they'll have achlorhyd, or they'll have hypochlorhydria, meaning they don't have enough hydrochloric acid, or maybe they'll have no hydrochloric acid. That's called achlorhydria. Pepsinogen from collateral damage. Yeah, they won't make pepsinogen or pepsin. Intrinsic factor. No, they're not going to have that. Uh-oh, here comes the landscapers. Sorry about that. Those people are the bane of my existence. Especially when I'm lecturing, but really sorry. Nothing I can do. So, yeah, diminished intrinsic factor levels as well. Blood findings. Pretty much the same for megaloblastic anemia, but maybe there would be a vitamin 9 deficiency as well in megaloblastic anemia. But they'll have low B12. They'll have low B12 levels. But here's the one I like. What about gastrin levels? Well, if you don't have acid in your stomach, there's nothing to shut off the turnoff system, right? The antral D cells, they're not no somatostatin, so gastrin just flows like a river, and so you have too much gastrin in your bloodstream, so you have hypergastrinemia. You also have pancytopenia, because we're going to learn that B12 is very important for erythropoiesis, for the making of red blood cells in the bone marrow. And DNA synthesis is screwed up without B12, and you make funky looking and immature and short-lived red blood cells. And white cells are mutated, platelets are mutated, but not as bad as red blood cells. But they don't have good hemoglobin, so it's just kind of a mess, honestly. We'll take a look at what that looks like. But pancytopenia means there's a deficiency of all of the normal cellular elements of blood. And we'll look at some more here, findings, some microscopic findings. I guess we're looking at them now. So you look in the blood work and you see macrocytosis. What does that mean? That means the red blood cells are gigantic, as immature blood cells are, and they're mutated. They have strange shapes, and if they have strange shapes, that's called poikilocytosis. And I expect you to know these words, because you can't get away with boards without knowing these words. Unequal size, you have some big ones and some small ones, some mutated. That's called anisocytosis. Anisocytosis means unequal size red blood cells. And then the neutrophils, which usually have no more than 3 lobes, they have 6, 7, 8. So you have hypersegmented neutrophils. These are all signs that DNA synthesis is messed up and there's not enough vitamin B12 around. Folic acid doesn't do this as bad as vitamin B12 does. Folic acid is a little... I'll wait till you get to nutrition. I'm sure she'll kind of keep working on that one. Explain that. So here, have you had that blood class, that lab class? I'm not sure if you've had it. I don't. Maybe not. But from undergraduate, you've all studied this, right? These are the normal cellular elements of blood. There's a lymphocyte. Particularly note the red blood cells. They have that kind of pale area in the middle. But they're lymphocyte. They're like way smaller than a lymphocyte. They're smaller than all of these white blood cells, these monocytes, basophils, neutrophils. Neutrophils got 3 little nuclei, no more than that. And then there's a baby, immature one. It's called a band neutrophil. But we're interested in these red blood cells, and these guys all look pretty darn good. Okay, now here is a patient with pernicious anemia, or you could say megaloblastic anemia, because if you have pernicious anemia, you have megaloblastic anemia. If you have pernicious anemia, you have vitamin B12 deficiency, and you have megaloblastic anemia. Or you will if it hasn't started yet, you certainly will very soon. But here's that same monocyte. Look at this gigantic red blood cell. And look at the different shapes, poikilocytosis. And then we have different sizes. There's a little one, and there's a big one. Anisocytosis is unequal sized. So we got all that stuff going on. What else do we got? Classic of megaloblastic anemia is neutrophil hypersegmentation. So that's an eosinophil right there. But that's kind of what a normal neutrophil should look like. It should not look like this. This is crazy. 1, 2, 3, 4, 5, 6, 7, 8 of them there. 1, 2, 3, 4, 5 in this one. So this is classic megaloblastic anemia. The red blood cells in this patient, how do they look? Well, they got some big ones. There's a big one. There's a big one. There's a big one there. So it's definitely megaloblastic anemia. So let's talk about megaloblastic anemia. It mainly occurs, its number one cause is pernicious anemia, or its number one cause, because there's other causes of vitamin B12 deficiency. What if you have a tapeworm and it's eating all your vitamin B? Then you can get a vitamin B12 deficiency. So there's other causes. But the most common cause of megaloblastic anemia is a vitamin B12 deficiency. What's the most common cause of vitamin B12 deficiency? Yeah, pernicious anemia. Okay, folic acid deficiency can also cause it. It is considered one of the macrocytic anemias. I'll leave that at that because we'd fall down the rabbit hole on that one, and I'm already falling down the rabbit hole enough. This is GIGU. Bone marrow hematopoiesis is messed up. So that's the bone marrow creation of all blood cell elements is messed up. But the one that's really messed up is the making of red blood cells, and that's called erythropoiesis. And that's because, again, B12 is needed for normal DNA synthesis. A little deeper, decreased vitamin B12 and or 9 results in more so with vitamin B12, but the erythrocyte nuclei is really tiny. It's underdeveloped, but they have tons of cytoplasm. Specifically, you could say that they have nuclear to cytoplasmic dissociation. That's another classic finding of megaloblastic anemia. And the cell's apoptotic clock is turned on too much, so they don't stay alive that long. You can test their mean cellular volume, or their MCV, and it's way too big because they have too much cytoplasm. The beans, the granulocytes, basophils, eosinophils, neutrophils, are often hypersegmented, especially the neutrophils, as we've already shown you. All right. Why am I hitting this so hard? Because there's another sequelae of vitamin B12 deficiency that could bring these patients right into your office complaining of sciatica. They'll go, I have sciatica. And you'll say, where's your sciatica? It's in my right leg, my left leg. You know what? It's in my arms too. You get this weird neuropathic pain. First question that pops into your head is, do you have a mother or father with any autoimmune disease? Do you have autoimmune disease? Because you're thinking that they have vitamin B12 deficiency. Still today, when I do my consultation work on the weekends, I always ask the patient about that. If they have, especially if they have that weird sciatica where the MRIs are normal. So the nerves, the myelinated nerves, myelination is good, right? I don't need to go in a big talk about that. But that's like a wiring. If you have an electrical wire shooting a current down it, you need an insulation around that current to prevent short circuiting. And that's what, in a way, myelin is that, in a way. And it also allows the current to move faster because it jumps, saltatory conduction and all that stuff. But what we found, vitamin B12 is an enzyme, or is a coenzyme or cofactor needed to clear methylmalonic acid from the body. And they found that in patients with B12 deficiency, that methylmalonic acid in turn breaks down into a bunch, or its accumulation in nerves causes a huge fatty acid deposition in the myelin. And fatty acids just come into the area and they take over, and it wrecks the myelin. And that, Robbins admits, that's really the only theory that at the time of his writing was around, and it's probably not right, but that is one of the leading theories, because there are some faults with the theories. But currently the only person in this conference. So that's not good. So yeah, we're back to school, and stupid Spectrum still hasn't fixed the node. So around 2 o'clock, this kind of stuff will happen. So this one's going on YouTube because I think I lost you. Maybe I'll come back on. I don't know, but I'll keep going. But anyway, so you could say that vitamin B12 deficiency causes an infiltration of the myelinated nerves with fat. It's a fatty infiltration. Well, you really shouldn't say that, though, because it's a fatty acid infiltration. All right. Neurological findings may develop before the anemia even develops. So they may come into your office with this leg pain, and yeah, even before the blood work. I mean, blood is usually one of the first things, but not all the time. Sometimes they get problems with the myelin, and they're getting pain in their legs. And you think, God, it seems like a diabetic pain, but they're not diabetic. Then you need to think of vitamin B12. That's kind of out of place, but after the peripheral nerves get beat up, the myelin in the noodle can be affected. And when this disease is well along its course, 75% of untreated people will develop problems with the CNS because of this. All sorts of deficits. Symmetrical dysthesias can occur in the upper and lower extremities. A dysthesia is a painful paresthesia, which includes tingling, burning, and numbness. That's like sciatica in a way. Why does it happen? Because there's not enough myelin. The myelin's not working. It's filled with fatty acids, and it's broken. And it can be devastating. Great slide here. Look at everything on this slide. Multiple sclerosis can do this. It's a demyelinating disease. I mean, people who come in with this weird pain, especially if their MRI is normal and they have pain in both legs, think MS. Think vitamin B12 deficiency. Lyme's disease is notorious demyelinating disease that I've caught several times in the last year or so. That people don't, family docs, especially if they haven't seen a neurologist, family docs don't know that. You guys should know this slide like the back of your hand. Do they have diabetes? They could develop a small fiber neuropathy because of this. Guillain-Barré's I've never caught a case of that in my entire career, but it's always on the list. Or maybe they do have they haven't had an MRI and they have a huge disc herniation and it's crushed the traversing nerve roots, and now, they got bilateral radicular pain. That does happen. So more neurofinding, they can have ataxia, right? That's a loss of coordination of movement, secondary to muscle spasticity, or getting twitchy. Sometimes they'll get fasciculations going before, and that ends up to be a demyelination of the dorsal columns of the spinal cord. That's good at causing ataxia. You'll have upper motor neuron lesion signs in these patients. Babinski's test, all those tests that you learned are important to do. You don't forget those after you leave school. Positive Romberg's test can be seen. That's a great test for cervical myelopathy secondary to central stenosis. Do they have balance? You guys know what that test is. Hold your feet together, close your eyes, and see how wobbly you get. Make sure somebody's there. Got a YouTube video on how to do that. Memory loss and dementia, all caused from vitamin B12 deficiency. What else? We talked about this a little more specific, though, about the demyelination in the CNS. Specifically, it can hit the dorsal or the lateral tract. So how do you tell the difference between a demyelination in the dorsal tract versus the lateral spinal tract? Well, positive Babinski's usually means a lateral tract degeneration. Ataxia, which is like drunk walking, or they just are unstable, really wobbly walking, that's usually a dorsal tract degeneration. Those are the ones that are usually seen more with cervical stenosis, which is called cervical myelopathy. And it can cause axon death if it's not treated, and cause spastic paralysis, sensory ataxia, severe dysthesias with pain, and maybe peripheral nerve loss, sensory loss as well. Okay, how about some other causes of megaloblastic anemia? Well, we already said folic acid deficiency. We said certain medications. I won't list the medications, but certain medications can do the trick here. And just running a speed test to see wondering if you guys came back to me, because it dropped for a while. And it looks like our internet is back on now. So diseases that interfere with, there's other diseases that interfere with DNA synthesis, like HIV. The virus loves it to get into cells and destroy that. Or myelodysplastic disorders, like some of the leukemias can do that. Let's see. How about some other associated disorders? Type A pernicious anemia is autoimmune, so maybe they have other autoimmune diseases like diabetes mellitus, Hashimoto's thyroiditis, vitiligo, which we'll look at in seventh quarter. Checking my time because I got to check in with you guys here in a little while. So look for those. Those are associated diseases. How about other associations of type A, the run-of-the-mill pernicious anemia? How about gastric carcinoma? We will learn that type A pernicious anemia, or the autoimmune pernicious anemia, those patients are at risk for atrophic gastritis, which carries a huge risk for gastric carcinoma. We know how fatal that one is. That's a horrible diagnosis. That's like the esophagus. In fact, there's a 26-fold, not a 2 or 3 or 4-fold. 4-folds, that's a big risk. This is a 26-fold. It's crazy risk for carcinoma, specifically in the fundic region, because that's the region that was beat up by the attack. Iron deficiency anemia is another one. I should have spent a little more time with that. But you need vitamin B12 around to properly digest iron. If you don't have vitamin B12 floating around in your blood, it's hard to digest iron. And so about a quarter of the patients with iron or with pernicious or with vitamin B12 deficiency via whatever will have iron deficiency anemia as well. And the exact mechanism isn't sure, but we know we need vitamin B12 floating around in the blood to properly absorb iron, but they don't know the complete mechanism for that. And Hashimoto's disease, about 10% of the patients will get Hashimoto's disease as well. How about some other findings? The old shiny tongue, atrophic glossitis. Gloss kind of means tongue. So you can get an atrophic glossitis or the bald tongue. There's a whole bunch of AKAs for that. That's basically an autoimmune attack of the cells in the tongue, which kind of resemble parietal cells. There's a picture of it. Other causes of B12 deficiency. And sometimes they call these type B pernicious anemia. This is the medical Winthrop's hematology. So a type B pernicious anemia means it's not caused by an autoimmune attack, but it's an infection of some kind, and it's probably the culprit is a chronic H. pylori infection. H. pylori is a menace, and we're going to look at that when we get to the gastropathies. It starts by attacking the pyloric, the antral region of the stomach, and if it's not snuffed out, it can take over the entire stomach. That's usually the pattern with this thing. But it does cause an atrophic multifocal gastritis, and yeah, if you wreck your stomach because of this infection with the bug, it can mess up the release of hydrochloric acid, pepsinogen, and intrinsic factor. So, yep, chronic HP infection destroys the stomach, the fundus glands, and you know the story. So you have hypogastremia. Is that right? No, I thought it was hypergastremia. Right? Therefore, you get decreased. Yeah, so, I know why. Do you know why that is? But wait a minute. But hydrochloric acid is decreased. So what about the D cells? They're not working, so G cells should be running wild, right? No, HP attacks, the very first thing it attacks is the antral region, which is where those G cells live. And so those guys are destroyed, so they can't make gastrin. So you do have hypogastremia, and that's a big indicator of decreased hydrochloric acid and decreased gastrin levels. It's got to be some type of infection that's destroyed all the cells of the stomach, not a specific attack against the fundus glands only. Additional blood testing for this chronic HP. So there's not going to be any autoantibodies around. The blood smears are going to look normal, no multi-segmented neutrophils. The B12 folic acid levels will be normal. So that's an HP infection. What about chronic pernicious anemia? Also, that one's has an AKA of intrinsic factor deficiency. This, and why they call it that, I don't know. It's just confusing, but that's Robbins. It is a genetic condition where the machinery, genes that build the machinery that make intrinsic factor are mutated and don't work. So it's not because there's an autoimmune attack or inflammation. You just can't, you're not very good at making intrinsic factor. And so you're going to get a B12 deficiency from that. How are your HCl levels going to be in your stomach in congenital pernicious anemia? I love questions about this stuff. Well, if the only problem is intrinsic factor machinery, hydrochloric acid will be fine. So gastrin levels will be normal. Hydrochloric acid, pepsinogen levels, those will all be normal. See how that works? So patients have no autoantibodies. They still get vitamin B12 deficiency, which leads to, or they still have this congenital pernicious anemia, which I hate this term, but because pernicious anemia, you think autoimmune. So you should really add this here. So it makes it confusing. Don't any of these authors, have they been out of school, or they don't teach and they don't realize how poor of storytellers or how confusing this stuff is? I just don't understand that. Anyway, Yeah, so same vitamin B12 deficiency, no matter what the cause, results in megaloblastic anemia. But a hydrochloric acid, pepsin levels will be normal, gastrin will be normal, evaluation of the stomach will be normal as well. There's no destruction of anything, there's no inflammation. How about another one? Malabsorptive pernicious anemia. So they would have to say that. And there's a lot of conditions that can just screw up the mechanism of vitamin B12 absorption. So how about a mutation in the salivary glands? And heptocrin is mutated. If heptocrin is mutated, your vitamin B12 will be destroyed by the stomach acid. Remember, we need heptocrin to bind with B12 and carry it out of the stomach. That's just one example. Maybe, I don't know, what are some more examples? That's enough examples. I got to keep moving along here. Proton pump mutations. Yeah, maybe we have genes in the proton pumps that don't work. Just like the intrinsic factor machinery is broken, maybe you can have a proton pump manufacturer. Now, why they don't include intrinsic factor mutations under this category, I don't know. They should, because it results in the same type of thing. But yet they don't, and it makes it really confusing. And I'm sorry about that. Let's see, what else? Proton pump mutations. Are they going to have hypogastrinemia? Yeah, this is a problem with making HCl. If there's low HCl, you're going to have high gastrin levels. So that's hypergastrinemia with hypo or achlorhydria will be present in this condition. How about pancreatic insufficiency? Well, that is a rare thing, despite what you hear on the radio all the time. They're really pushing a new drug for this lately. But you can have a pancreatic insufficiency where you don't release, amongst other things, you don't release the pancreatic proteases. We need those. Without pancreatic proteases, you can't get heptocrin to break loose from the B12. Intrinsic factor will never bind. And B12 will still have a partner all the way down the ileum, all the way down the jejunum and ileum, but it can't bind to the cobam receptors. Cobam will only take intrinsic factor, the intrinsic factor B12 combination. So they won't bind. There will be no hypergastrinemia. There'll be no hypochlorhydria because all that machinery is working fine. We just, the story of B12 into the distal ileum is messed up. What about distal ileal disease? Crohn's disease, notorious for an inflammatory attack of the distal ileum, and there goes our cobam receptors, destroyed by people with Crohn's disease. And there you go. What about a tapeworm? Parasites. Tapeworms love B12. It's like candy to them. And they can steal all your vitamin B12, that nasty-looking thing. You get a B12 deficiency, megaloblastic anemia, but all your lab findings, your stomach juice findings will be fine because there's nothing wrong with any of the machinery. You'll secrete acid normal, intrinsic factor normal, everything's normal. But the intrinsic factor and B12 get eaten by this parasite. All right, let's get into disorders of the stomach here. Still got to keep going. So, new topic, stomach disorders. Let me take some water here. Can read the slide. That's right. Nearly 1/3 of all healthcare spending is secondary to GI problems. Gastroenterologists in California right now, the SARS-CoV-2 running wild. It'd probably take forever to get in, but when things were normal, it would take 5 to 6 months to get in to see a good GI doc. There's just so many patients, they just can't keep up with them. And it's a big cause of morbidity in this country. And there's lots of causes: inflammatory disease, cancers, infections, gastroenteritis, gastric carcinoma is one of the world's leading causes of death in more than third world countries. Dyspepsia we've talked about, but we're really going to talk about dyspepsia now. And that just means stomach upset. My tummy's upset. But what do they mean? Do they mean down by their symphysis pubis part of the tummy, or do they mean by the xiphoid process? It could be anywhere. And the word dyspepsia is kind of the main category. And there's several complaints that can check the diagnosis of dyspepsia. And these have been studied. This group of symptoms is called the dyspepsia symptom complex. And it is one of the most common GI complaints out there. It means difficult digestion, and it may be associated with eating. It may be associated with empty tummy. May be associated just kind of in between. Look at this number. This is not 0.01% of the population. This is 28% of the population has at least some dyspepsia on a month basis, or even daily. So, well, that doesn't make sense, does it? Experience daily/monthly. You can't have both of those. I think it was at least 28% of people. I need to get that out of there. 70. I don't have any words to remember 70. Oh, I have my paper here. Let me write 70 down. See if I can get rid of that. So 28% of the general public have at least a run-in. Oh, I see what it means. It means a daily, like once a month at least, they're going to have an upset stomach that lasts for the whole day. That's what I was trying to say there. Of those, only a minority of those will actually bother to go see, they're more of an annoyance. I don't need to see the doctor, which they should if it's a chronic problem. It could be cancer down there. And so these people are going to have at least two members of this dyspepsia symptom complex, which we need to look at. Interestingly, 50% of people with dyspepsia, it'll go away just with no rhyme nor reason to it, without any treatment. So it can take a year, it can take years, but sometimes things just settle down by themselves. But we'll learn about organic and functional dyspepsia here in a second. But let's look at the symptom dyspepsia symptom complex. So gastroenterologists know these, and you will know these as well. And if the patient complains about one of these symptoms, they have dyspepsia. It makes the diagnosis, because the patient's not going to come and go, "Doc, I think I have dyspepsia." I mean, 99% of your patients aren't going to say that. They're going to say, "God, I eat food, just a little bit of food, my stomach gets so full I don't want to eat anymore." Or I eat just a normal meal, my stomach's upset, I feel like I overstuffed myself. So let's look at this clinical dyspepsia symptom complex right now. So you need to memorize these guys. The red ones, the famous group that studies this and tries unsuccessfully to kind of standardize the nomenclature, is the Rome 3 guidelines, was the last big group where gastroenterologists, famous ones from every nation in the planet, got together and tried to get everybody on the same page, because it's such a mess. And the red ones are the ones they could agree on. The ones in black are the standard ones that have been around forever. And so you put them all together, we got everything covered. So number one is a bothersome postprandial fullness. So postprandial means after your meal. So you eat a meal. It's not a particularly big meal. It's a small meal. And you should be okay, and then your stomach hurts after you've eaten. 90% of people complain. So it's not while you're eating. You can eat the normal meal, but you just don't feel good afterwards. Stomach bloating, it's number 2. And these are in order. Epigastric pain, so pain right by your xiphoid after or during eating. Nausea, I know how that one's up there so high, because that's not my experience with this condition, but nevertheless, some people get nauseated. Early satiation is confusing. So this one is, they can't eat. They go out to dinner, a nice dinner, and they take a few bites, and they're like, "Okay, I don't want any more." And, what's the matter? Why aren't you eating more? I'm full. I don't. It's like they have no desire to eat anymore. Probably because if they do, they will get this one. So these two are probably related, but they don't cheap date at least. They go out and eat a salad, half a salad, and they don't eat anymore. But that's not no way to live, right? And they're going to start to lose weight, too much weight, and that's a problem. Burping is a big problem for some people. Epigastric burning. And I know what you're thinking. Why in the world don't they clump these two together? But the wisdom of all those gastroenterologists throughout the world said there's a definite distinction between flat-out pain and burning. So they're two separate categories. And then vomiting is that one probably shouldn't be on there. But nevertheless, here's a study done in 2016. Schlesinger talked about it in Schlesinger's 2016. Over 600 patients who had dyspepsia were questioned about it. And specifically, they had a questionnaire, and they were explained and had to be taught what the difference of these symptoms were. And they volunteered to take it, and here's what they had. So the number one symptom, about 90% of them had this postprandial fullness, this bothersome, and they eat a small meal, everything seems good, and then, maybe 15 minutes, 20 minutes, they have upset stomach. Bloating, and you can see it was they eat a little meal and they feel like they've eaten, like a caveman or something, eating a saber-toothed tiger, and they're just stuffed. But they only ate a little tiny bit, and they're just completely bloated and overfull. And then flat-out pain, epigastric pain, nausea, and etc. All right, so there's two types of dyspepsia. One is organic dyspepsia, one is functional dyspepsia. Organic, like everything else we've talked about, means there's a reason for this pain. 30% of patients fall into this category. So it's a peptic. They have a peptic ulcer. They have one of the gastropathies. They have non-atrophic multifocal gastritis. And the 70%, the lion's share, just like essential hypertension, we don't know what's causing it. 70% of them, they don't know what the reason is. I think a big reason is because they don't look enough. I'm going to show you the theories of what's causing this. But if you don't follow up with it, you're not going to find it. I think that's why that number's so big. So we'll look at some of those. Interestingly, too, a side note, although I don't have time for side notes, but I was set up to do the first chiropractic study on functional dyspepsia with Stanford. My gastroenterologist was all into this, and we're going to use our clinics, and we're going to see if chiropractic could help functional dyspepsia. All the chiropractic studies are on organic dyspepsia. We know that's not going to help. Functional dyspepsia might be an enteric nervous system problem. Chiropractic's not really explained fully, but it's kind of nebulous. This diagnosis is kind of nebulous. Really curious to see if it can help people with functional dyspepsia, and so was the Stanford doc. But COVID struck, and now everything is off. But eventually, I'm hope to do that study with him. Now somebody probably heard this and will get out and beat me to the study. But all right, organic dyspepsia means we know what's wrong. What are the causes of stomach upset? GERD, we've talked about. Usually causes retrosternal pain, but not always. Sometimes it causes precordial pain over the heart. Sometimes it causes pain down in the xiphoid region. That's about 20% of the dyspepsia pie. The dreaded gastropathies account for 50% of the dyspepsia pie. From non-atrophic gastritis like an HP infection to the atrophic gastritis like an autoimmune attack against parietal cells. We'll look at those. Peptic ulcer disease, about 7% of the pie. Carcinoma, 1% of the pie. That's a bad one, but it is a piece of the pie. Pancreatic disorders, biliary tract disorders, cholelithiasis, and biliary colic can be mistaken, especially early on for pain. We should do a tiny rabbit hole. Talk about cholelithiasis, because I never get time to get into the liver and such. We always run out of time. But there's a gallbladder. You know the anatomy. Those are gallstones. If they sit here, no big deal. But sometimes they get up here and get stuck in the neck of the gallbladder, like both of my daughters within the last 2 years had to have their gallbladders removed because of cholithiasis. And they both have the same thing. Horrible crescendo, decrescendo pain. If a stone gets stuck here, just like in your small intestine, this is capable of a peristaltic wave. And this gallbladder will squeeze harder and harder, trying to shoot the stone through. And it causes excruciating pain. And then it has to relax, to reset. And then the pain goes away. Then it comes again. So that's like a crescendo, decrescendo type pain. Same thing if it gets jammed in here in the common bile duct. But yeah, it can be stuck anywhere. Not a good if it gets stuck here, right, in the ampulla of Vater, or if it backs up into the main pancreatic duct. I mean, you can digest your pancreas like that, so they can be serious. Let's see, more causes. Gastrointestinal infection is a big one. I didn't get a percentage. I would say that's got to be the number one cause, but I mean, in a way, because this one passes fairly quickly. But nevertheless, gastroenteritis can certainly cause dyspepsia. Maybe it's like a smoldering virus. We can add the SARS-CoV-2 virus in here to this. There's the norovirus. We got SARS-CoV-2 does present with dyspepsia in some people. What a strange bug that thing is. Inflammatory disorder, celiac disease, Crohn's disease, ulcerative colitis, eosinophilic gastroenteritis, lymphocytic, there's tons, sarcoidosis, there's tons of inflammatory diseases that can cause stomach upset. These are less common ones. I usually don't hit these, or maybe, but I guess I have hit these. There's so many causes of stomach pain. It's kind of the right. Even Mr. Spock is like, what the holy halibut? Or what does that guy say? I forget what SpongeBob says. But it's surprising. Thyroid disease in some people, Addison's disease, hyperparathyroidism, gastroparesis, myocardial infarction. Maybe you're getting some ischemia of the heart, morning sickness, renal failure, lymphoma, amyloidosis. Maybe you got a volvulus starting, your intestines are twisting up. Maybe you got a stone or a blood clot in the superior mesenteric artery and you're getting some ischemia and the intestines are starting to hurt from that blood clot. What about food triggers? So, although the research isn't super strong in this area, some common ones are spicy foods. Some of the ones we talked about with GERD: chocolate, peppers, tomato-based salt, citric fruits, alcohol. Medications, COX-1s, we talked about, those are definitely stomach irritators. 20% of almost a quarter, a fifth of the patients who take them have stomach problems. COX-2 inhibitors are better. 10% of that 20 go on for dangerous peptic ulcers. We'll talk about PUD when the time comes. COX-2 inhibitors, we talked about them. They're better on the stomach. They're supposed to spare the gastromucosal barrier, but some people are sensitive to them as well. Aspirin, iron supplements, notorious. Narcotics, people with chronic back pain, although you don't see that much anymore because the pendulum has swung too far away from opioids. Now people who need them can't get them. Antibiotics, Some people with gastroenteritis, they're given antibiotics and that makes the pain worse. Digoxin, estrogen, levodopa. There's tons of things, medications that can upset the stomach. Let's see. Let me just look at one slide. Functional dyspepsia, and we'll call it a day. Or let me lie. I'll go a couple slides here. So this is the most common, more common than organic dyspepsia. Most people, they stick a scope down there. They don't know what the heck is wrong with somebody. They just have stomach upset. But we're going to look at some of the possible, in the future, official causes. Then it would become an organic dyspepsia once some of these theories become proven. But right now they're not proven. They're just kind of theories with research behind them, though. But functional dyspepsia is a cluster of dyspeptic-like symptoms. There's 8 of them. And they're the same symptoms. I mean, they're that symptom complex. So dyspepsia is dyspepsia. You get those symptoms, makes the diagnosis. But here comes my friend, the Leaf blower. He must have went on a break and now he's back. Anyway, there are 8 proposed etiologies, and this is where we're going to stop it. Or 6 proposed etiologies that could explain this. There's delayed gastric emptying, impaired gastric accommodation to a meal, hypersensitivity to gastric distension, altered duodenal sensitivity to lipids or acids, abnormal intestinal motility, central nervous system dysfunction. So we will look at that. Let's stop it right there at slide 90. I'll try to make this up. I'm trying to stay on the same slides, but all right, see you later. Let's hope this worked. Camtasia, did you save us? Looks like it.